Let's talk about peptic ulcer disease. We're going to start off with, what is it? Peptic ulcer disease is a mucosal lesion of the stomach or duodenum, and it results when mucosal defenses become impaired and no longer protect the epithelium from the effects of acid and pepsin. Of course, acid is the hydrochloric acid, and pepsin is the enzyme that breaks down food particles when it gets in the stomach. And they're strong enough to break down that stuff. They're also strong enough to become a problem if the defense system in our bodies becomes less able to deal with it. There are three types of peptic ulcer disease: gastric, which are caused by H. pylori infection; duodenal, which is also caused by H. pylori infection; and stress ulcers, which are less common. H. pylori is believed to be spread through contaminated food or water. Contact with stool, vomitus, and saliva from an infected person can put one at risk. So again, use good hand washing techniques. How does H. pylori cause the damage? H. pylori is a bacteria, and it causes an activation of cytokines and neutrophils, which then cause epithelial cell necrosis. H. pylori produces urease, which breaks urea down into ammonia, which neutralizes the acidity of the stomach. Presence of urease in lab work will confirm the presence of H. pylori, because it's not going to be there if H. pylori isn't there. H. pylori has a helical shape which allows the bacteria to burrow into the mucous layer of the stomach and become undetectable by the body's immune cells. And this is basically a picture of a helical shape. They can burrow in, they spiral around and burrow in. It makes it really hard for the immune cells to find them. All right, this is a diagram or schematic of gastric and duodenal ulcers. Looking at this picture on the top left, this is a gastric ulcer, and this occurs because the normal gastric secretion and delayed stomach emptying time will cause this gastric acid to hang around here longer than it normally would. And so that causes an erosion in the stomach lining. Now you add H. pylori bacteria to this problem, and you get portals of entry for that bacteria that will go into the stomach lining. With duodenal ulcers, those that occur beyond that stomach pyloric sphincter, you have a normal diffusion of acid back into the stomach with an increased secretion of gastric acid and increased stomach emptying. So there's more acid coming down here, see it? And then it tries to come out and it gets too much there. It comes out so fast that duodenum can't handle it. Looking at the schematic over on the right, this is an example of a gastric ulcer. This is an example of a duodenal ulcer. And one is caused by delayed emptying out, and the other is caused by too much going in. Okay? We'll talk about that. I think that'll be clarified even more later. Gastric ulcers develop in the antrum of the stomach near the acid-secreting mucosa. When a break in the mucosal barrier, this break would be caused by that bacteria. When that happens, hydrochloric acid injures the epithelium. Back diffusion of acid or dysfunction of this pyloric sphincter here may then result in a gastric or stomach ulcer. Just not able to empty out, it hangs out here. There's a bacterial portal of entry, and then you get the ulcer. Gastric emptying is often delayed in patients with gastric ulcerations. This causes regurgitation of the duodenal contents, which worsens the gastric mucosal injury. So as even more gastric acid flows back up, we have even more injury. Gastric ulcers are deep and penetrating and usually occur on the lesser curvature of the stomach near the pylorus, and this is the lesser curvature of the stomach. Here's your greater curvature out here, but the lesser curvature where it's most likely to happen. Comparatively, the duodenal ulcers will occur in the upper portion of the duodenum. They are deep, sharply demarcated lesions that penetrate through the mucosa and submucosa into the muscularis or muscle layer of the duodenum right there. The floor of the ulcer consists of a necrotic area resulting in granulation tissue and surrounded by areas of fibrosis, and that's what you're going to see there. The main feature is high gastric acid secretion. pH levels will be low, meaning that acid is high for long periods of time, just kind of hangs out there and creates a problem, eats away. Protein-rich meals, calcium, and vagus nerve excitation will stimulate acid secretion. So those are contributing factors. Combined with hypersecretion, a rapid emptying of food from the stomach reduces the buffering effect of food. So a large acid bolus is delivered to the duodenum. So you've got a lot of food, which sometimes will buffer it at least for half an hour or so. Instead, it just comes out fast, and you've got all that acid that it promotes that are, again, presented to the duodenum. The inhibitory secretory mechanisms are insufficient to deal with this high acid produced. Stress ulcers are the ones we think we all get. They are the least common, but it feels like that we are the most risk for these in this day and age. Stress ulcers are the product of acute gastric mucosal lesions that occur after an acute medical crisis or trauma. And some that were mentioned in your book are sepsis, extensive burns, increased intracranial pressure, or head injuries. Stress ulcers are multiple shallow erosions of the stomach and occasionally the proximal duodenum. Bleeding caused by gastric erosion is the main manifestation of acute stress ulcers. Multifocal lesions occur. They begin as areas of ischemia and evolve into ulcerations that may end up in hemorrhage. These are pictures of a chronic peptic ulcer here on the left. You can see how it has been eaten away into the actual tissue. And then over here are acute gastric ulcers. Do you see the multifocal lesions? All those little black areas are little lesions that are eaten away at the stomach area. This is a duodenal ulcer on the left. You kind of have to, I wouldn't be able to have told you that, but looking at the schematic here, they've taken a probe down in here, down here, and it's in the duodenum, and that's what they see. That's the probe that they're taking a picture of that. You can see the ulcer there. Over on the right is gastric ulcer. They've taken their little photo probe down, and they're looking in the gastric area, and they see an ulcer in the gastric stomach. What are the complications of ulcers? Hemorrhage is the most serious complication, and it is more often in patients with gastric ulcers than in older adults than with duodenal or stress ulcers. What the patient will see is vomiting of bright red or coffee ground blood. Hematemesis usually indicates bleeding at or above the duodenal jejunal junction or the upper GI area. Minimal bleeding from ulcers is manifested by occult blood you cannot see, in a dark tarry stool, and that's known as melena. Results from digestion of blood within the duodenum and small intestine will cause that melena impact on the stool where it becomes dark and tarry. Another complication of ulcers is that of perforation. Perforation occurs when the ulcer becomes so deep that the entire thickness of the stomach or duodenum is worn away. Patients will develop a sudden sharp pain in the mid-epigastric region, and this spreads throughout the abdomen. The abdomen will become tender, rigid, and board-like. The patient often assumes a fetal position because that's going to minimize tension on the abdominal muscles. So if you have someone curled up in that fetal position, always consider the possibility of an ulcer that is perforated. Bacterial septicemia and hypovolemic shock will follow. Peristalsis will diminish and paralytic ileus will occur. Peptic ulcer perforation is a surgical emergency. These patients can die very quickly. Signs and symptoms of an upper GI bleed that would indicate the need to be concerned about the perforation is the bright red or coffee ground vomitus, the melena, tarry stools, decrease in blood pressure. These are your symptoms of hypovolemic shock. Remember the decrease in blood pressure, increase in the heart rate, weak peripheral pulses, acute confusion in the older adults, vertigo, dizziness or lightheadedness as they get decreased oxygen saturation in their head, syncope, loss of consciousness, and of course a decrease in the H&H as they bleed. The final two complications of ulcers are pyloric obstruction and intractable disease. Pyloric obstruction occurs in a small percentage of patients. It is manifested by vomiting caused by stasis and gastric distension. So the stuff doesn't go anywhere to go. It cannot get out because there's an obstruction in that pyloric valve at the low end of the stomach. So they'll throw it up. Doesn't have anywhere to go down. It'll come out. As I said, the obstruction occurs at the pylorus and it's caused by scarring, edema, inflammation, or a combination of any of or all of those. Those can be as a result of long-term problems. Symptoms would be abdominal bloating, nausea, and vomiting. Intractable disease is the final complication we're going to discuss. Many patients with ulcers have a single episode with no reoccurrence. However, intractability may occur as a result of complications of ulcers, excessive stressors in a patient's life, or an inability to adhere to a long-term therapy. These patients would be referred to a gastroenterologist. The etiology of peptic ulcer disease, we've mentioned one, which is the H. pylori bacteria. It's the main etiology. But NSAIDs also contribute to their causation. NSAIDs will break down the mucosal barrier and they disrupt the mucosal protection that is mediated systemically by cyclooxygenase inhibition or COX inhibition. So in other words, having too much NSAID on board, it's going to prevent a protection that's normally in place that would prevent this. NSAIDs also cause a decrease in endogenous prostaglandins, which will result in a local gastric mucosal injury. They are very difficult to treat because these ulcers have a high rate of reoccurrence. How do we assess these patients? Let's start, of course, with our subjective, our history. Find the data that's related to risk factors. And these are just some of the many areas you'll want to ask your patient about. What is their alcohol intake and their tobacco use? Certain foods that increase symptoms. Tomatoes, caffeine beverages are a couple of them, but different people will have different symptomatology producer foods. Find out what bothers them personally, specifically. Find out what prescription medications they're on and the over-the-counter meds and herbs. And specifically, we're talking about steroids, chemotherapy, and of course those NSAIDs. Have they had any history of radiation treatments? Have they had a GI surgery, any partial gastrectomy, any weight loss surgeries dealing with that stomach that could put them at increased risk? Have they had a history of GI upset, pain, or any relationship to the eating or sleeping habits? If they go to bed or lay down too soon after eating, do they get symptoms? What foods, as I said before, what foods contribute to symptomatology? Do they have any changes in the pain that they had been experiencing? Has it started to escalate? Do they have dyspepsia? This is the most commonly reported symptom of pelvic ulcer disease, and it's described as a sharp, burning, or gnawing pain. Do they have nausea and vomiting? Those are most likely going to occur in your older adults, and again with that pyloric sphincter dysfunction where they have the obstruction. Moving into the objective assessment, what is the physical exam that you're going to do on these patients? Of course, let's talk about the epigastric tenderness. Is it present, and have the patient show you exactly where. When doing your abdominal exam, as we've mentioned before, start out gentle and then get a little more firm. Is the abdomen rigid, board-like? Is there rebound tenderness? Do they do okay when you push down, but when you let go, it hurts? What kind of pain is it? Strongly suspect perforation if these symptoms are present. Auscultation may reveal hyperactive bowel sounds initially, but then they may diminish with progression of the disease. Gastric ulcer pain usually occurs in the upper epigastrium with localization to the left of the midline. So find that on your body right now. Put an upper gastric and to the left. That's where you're going to have more like your gastric ulcer pain. It's aggravated by food. It occurs about 30 to 60 minutes after eating. That's the one that's food related. The duodenal ulcer pain is usually located to the right of or below the epigastrium. So go over to the right and down a little bit. That's where they're more likely to have duodenal ulcer pain. And that occurs 90 minutes to 3 hours after eating. And when you think about that system and how the organs line up, it makes complete sense. Food is first presented to the stomach, the gastric, and so that pain will occur very quickly, 30 to 60 minutes after eating. Whereas duodenal pain takes a while for the food to get beyond the stomach in the duodenal area, and so that's going to take from 90 minutes to 3 hours. We also want to check these patients for orthostatic hypertension and any signs of dehydration. Dizziness, especially when upright, may be a symptom of fluid volume deficit. Older adults are at higher risk of falling because of this. Let's really be careful with the older population. Psychosocially, let's assess the patient for how this disease is impacting their lifestyle. Does it have an impact on their occupation? Are they missing work because of it? How does it affect the family and the family functions? The social and leisure activities, are they not doing activities because of this problem? This assessment may also reveal information on the patient's ability to adhere to a prescribed treatment regimen and to obtain any needed social support. These patients are it's very vital that they maintain the treatment, the prevention plan that is outlined for them, and if they don't, they're going to get really sick. So let's find out if they're able to, willing to, what their motivation is to subscribe to that treatment regimen, and who in their family will help them stay on task. The laboratory diagnosis, there are 3 simple non-invasive tests to detect H. pylori in a patient's blood, breath, or stool. The first one we'll just mention is the serologic test for H. pylori antibodies. It is the most commonly used. It's just a blood test. You know, they draw the blood, send it off. On the other hand, it is not the most diagnostic of the tests. The urea breath test and the stool test have more accuracy to them. The urea breath test is one where the patients will swallow a capsule that has urea, not urine, urea made from basically an isotope of carbon. If H. pylori is present in the stomach, the urea is broken up and turned into carbon dioxide. This carbon dioxide is absorbed across the lining of the stomach and into the blood. And then it travels in the blood to the lungs, where it is excreted in the breath, breathing it out, carbon dioxide. Samples of the exhaled breath are collected, and the isotopic carbon in the exhaled carbon dioxide is measured. If the isotope is detected in the breath, it means that H. pylori is present in the stomach. If the isotope is not found, H. pylori is not present. When the H. pylori is effectively treated by antibiotics, the test changes from positive to negative, so it's a good way to evaluate therapeutic effectiveness just by breathing. The final diagnostic lab test that can be performed is a stool antigen test, which is performed on a stool specimen. That would also check for occult blood in the stool as well as the antigen for H. pylori. The breath test and stool antigen test are the more accurate tests, but the serologic test is more commonly used. EGD is the major diagnostic test for peptic ulcer disease. To actually visualize and make sure and confirm that it's not cancer or anything else, an EGD is done. Are you going to make me pronounce this? I'm going to try. Esophagogastroduodenoscopy. I did pretty good. The EGD is the most accurate test for diagnosis. It also allows for a biopsy to be done, and also they would check some of the fluid related for cancer cells. It may be repeated at 4 to 6 week intervals to evaluate the progress of healing in response to therapy. So it's a way to measure progress. GI bleeding, another final test, is GI bleeding may be tested using nuclear medicine scans. Management and the priorities. Pain management is a biggie, focusing on drug therapy and dietary changes to manage the pain of peptic ulcer disease. The purposes of drug therapy are basically these 4 items: to provide pain relief, to eliminate the H. pylori infection, to heal the ulcerations that have occurred, and of course to prevent reoccurrence. In the treatment plan, no single agent is effective. It needs a combination therapy, and it's called PPI triple therapy, which is used for up to 14 days. The PPI stands for proton pump inhibitor, and that is an example of that is Prevacid or lansoprazole, and also they have to have antibiotics to treat the actual bacteria. So 2 regimens that may be prescribed would be, one would be the metronidazole and tetracycline, or clarithromycin and amoxicillin, depending on allergies. So they would be on the proton pump inhibitor as well as to antibiotics to control the acid and the bacteria, to kill the bacteria. Proton pump inhibitors are the drug of choice for treating patients with acid-related disorders. And I've just listed 5 different medications here. I'm not going to go into detail about them on these slides. I do refer you to the chart in IGGI on page 1133 and 1134 for specifics. We are going to discuss these medications more in detail in class. So please get out the IGGI, open up your computer, and look at the chart 55-4 to get familiar with these different medications. What would be the pros and cons of each one? We're going to be working on that in class, okay? So get familiar a little bit before you come to class. PPIs should not be used for prolonged periods of time because they may contribute to osteoporotic related fractures, especially spinal fractures in older women. And I put psi there because I am on a PPI and I'm like, crap. Do one thing to fix and you get another thing you gotta worry about. But anyway, pick your poison, right? I'll just keep doing my exercises and taking my calcium. Okay, you didn't need to know all that. That's personal. Sorry. Okay, and then moving on, other medication implications would be omeprazole, which are Prilosec, and the over-the-counter Prilosec, which reduce the effect of clopidogrel, which is called Plavix, on antiplatelet drugs. So it's really important that these patients know that they need to report what other medicines they're on so that the provider knows what is not appropriate to order. PPIs should not be discontinued abruptly. in order to prevent rebound activation of the proton pump. We don't want that proton pump to just boom out again and start causing big problems. So the step-down approach must be used. Antacids will buffer gastric acid and prevent the formation of pepsin, which is the chief enzyme of digestion. And examples of this would be Mylanta and Maalox. Interestingly, Tums is a potent antacid, but it triggers gastrin release, which causes a rebound acid secretion. So Tums are not the great acid reducer we were hoping for. Its use in acid inhibition is not recommended. Of course, we always need to teach our patients how to do best practice and benefit from any medical regimen they're on. Patients with past or present heart failure must avoid antacids with high sodium content. For obvious reasons to us, the high sodium causes fluid retention, which can increase the heart problems. So examples of those antacids would be those that contain aluminum hydroxide, magnesium hydroxide, sodium bicarb, or simethicone. Sucralfate, or otherwise known as Carafate, is a mucosal barrier fortifier or protector of the mucosal lining. They form complexes with proteins at the base of a peptic ulcer, and this protective coat prevents further digestive action of both acid and pepsin. Sucralfate does not inhibit acid secretion. It binds bile acids and pepsins, prevents them from causing injury to the mucosa. Hangs on to them. You're not going there. You're not going to hurt that stomach lining. Pepto-Bismol is actually a pretty good antacid. It inhibits H. pylori from binding to the mucosal lining and stimulates mucosal protection as well, and prostaglandin production. These patients must not take aspirin while on Pepto-Bismol, though, because Pepto-Bismol is bismuth subsalicylate, which is a salicylic acid, which is what aspirin is, and so that can cause an overdose of salicylic acid, so we don't want to do that. We must teach these patients that their stools may become discolored black, but that this is temporary and harmless. If they see a really black stool, they might freak out and think it's what? Blood, yeah. Nutritional teaching. Interestingly, there is no evidence that dietary restriction reduces gastric acid secretion or promotes tissue healing. So it isn't like we have a rule book on nutrition and what to eat and what not to eat. Food itself will act as an antacid by neutralizing gastric acid for about 30 to 60 minutes. That's why some of these patients will, eat a piece of bread or something that will take care of the initial gastric acid feel, but then a rebounding gastric acid secretion may occur. So even though it helps in the moment, they might get that rebound after they've done eating as more gastric acid gets produced to digest whatever they just ate. We need to teach these patients to exclude any food that causes discomfort. And each patient's going to be individualized, so they need to learn those that exacerbate symptoms for themselves and avoid them. Avoiding bedtime snacks, eating and then laying down may, eating of course will stimulate gastric acid secretion, and then if they lay down, that may cause a reflux back up. Avoid alcohol and tobacco because these also stimulate gastric acid secretion. And the final teaching is that of complementary therapies. Methods to reduce stress. What can we do to ease up on some of the worry that our stomach goes through? Really, our bodies portray the things that we worry about. So whatever works for each person, yoga for some, meditation, maybe prayer, journaling, hypnosis, imagery, help the patient identify ways to manage stress. Turning off the TV will help a lot of people. We also need to teach them when to seek help. Seek immediate medical attention if they experience any of the following: Sharp, sudden, persistent, and severe epigastric or abdominal pain. As we know, that could be a perforation. Bloody or black stools. Bloody vomit or vomit that looks like coffee grounds. Any of those can be worries about hemorrhaging. How do we manage an upper GI bleed? Blood loss from peptic ulcer disease has a high morbidity and mortality rate. Complications will quickly occur from fluid volume loss secondary to vomiting and bleeding. The emphasis for these patients is on prevention, early management, and fast identification of perforation and gastric outlet obstruction. Those are the two bad ones. In some cases, surgical treatment is necessary. Emergency upper GI bleeding is a life-threatening emergency. It needs supportive therapy to prevent hypovolemic shock and, of course, possible death. The purpose of treatment is to expand IV fluid in a patient who is volume depleted. We need to do careful monitoring of I&O and overall fluid status. Older adults present even greater concern and challenge because they have a possible fluid overload during treatment, so they must be monitored very, very closely. Mild bleeding is described as that less than 500 milliliters. And in these patients, they may have slight feelings of weakness and mild perspiration. In blood loss greater than 1,000 milliliters in 24 hours, these patients may develop manifestations of shock. They would have hypotension, chills, palpitations, diaphoresis, and a weak, thready pulse. Combination therapy may be indicated. An NG tube will be placed for various reasons. One is to determine the presence or absence of blood in the stomach. Let's see what's down there. We can also use that to assess the rate of bleeding, to prevent gastric dilation and just the status of the stuff sitting in there causing more problems. And we can also administer lavage therapy, and that's where they put some either normal saline, sterile water, even tap water, because the stomach is not sterile, but they put fluid down there and keep lavaging it out, suctioning it back out, trying to clear up the bleeding, to get it to be less of blood and more of an area that doesn't have blood in it, which, you know, when we have blood sitting around in there, increased risk of infection. Endoscopic therapy is sometimes done to isolate the bleeding artery in order to embolize it or clot it. This clotting can be done either via chemical method or heat, electric current, or laser, or close the affected vessel with a band or a clip. But the point is to stop the bleeding. Another way to do this is through interventional radiology. They may go through either the femoral or brachial artery. This is quite a fascinating procedure. If you ever get a chance to watch one, I would highly recommend it. An arteriogram is performed to identify the arterial anatomy and find the exact location of the bleeding. Once they locate where that problem is, medication is injected into the blood vessels to stop the bleeding at that site. Acid suppression is another step in managing the upper GI bleed. It must be done aggressively. When the bleeding has finally stopped, a clot is going to form in the ulcer crater, and we need to preserve that clot. We don't want to disturb it, we want to preserve it, and so acid suppression is used to stabilize the clot by raising the pH level of the gastric contents, making it less acidic. Perforation is managed by immediately replacing fluid, blood, and electrolytes. It is truly an emergency situation. They need antibiotics. We need to keep these patients NPO and maintain the NG suction to drain gastric secretions and prevent further spillage. With pyloric obstruction, these are caused by edema, spasm, or scar tissue. Okay? The symptoms these patients get may include feelings of fullness, distension, nausea after eating. They may vomit a large amount of undigested food. If it's sitting in there, it can't do much, so it just comes back out. Treatment is directed towards restoring the fluid and electrolyte balance and decompressing the stomach. This is going to take the NG section. We need to correct metabolic alkalosis and dehydration. Check the patient for retention of gastric contents, and we do that by clamping the NG tube. After the first 3 days it's in, we start wanting to know if we're making a difference, so they clamp the tube for about 30 minutes. If there's less than 50 milliliters of gastric contents after that 30-minute of clamping, these patients may be advanced to oral fluids. This is the way that we evaluate if they're starting to increase motility and an ability to use their GI tract again. How about home care? We need to teach these patients and their families the risk factors for reoccurrence and help them make lifestyle changes to improve outcomes. Evaluate what is the problem that they won't or can't adapt to a new lifestyle that will prevent reoccurrence. Help them investigate and problem solve and find solutions. We also need to teach them to recognize new complications and what to do if they occur, and especially abdominal pain, nausea, vomiting, black tarry stools, and weakness or dizziness. The expected desired outcomes for these patients are that they will not have active peptic ulcer disease or associated complications. They will verbalize pain relief or control. They will adhere to the drug regimen and lifestyle changes to prevent reoccurrence and heal the ulcer, and they will not experience an upper GI bleed, and if they do have a GI bleed, it will be promptly and effectively managed.